Good morning, ladies and gentlemen. First of all, I would like to thank very much organizers for inviting me to this very nice meeting. I have to recognize that when I was given the title management, and I realized that the previous talk was diagnosis, and the next one was therapy, I didn't know what to talk about. So what I did was first go to the sorry. No. This one.
Yeah, this one.
I went to the Collins Dictionary because being a Spanish and speaking Spanglish, you are never sure about that. So I discovered that the definition of management is this one: is that technique, practice or science of managing, controlling or dealing with. Or another exception is that the specific treatment of a disease, disorder, etc. So after an email from Sonja, I think that email helped me very much. I decided to talk about diagnosis, the diagnosis time point, also prognosis, and some of the problems that Sonja has shared with us. So we are here because of these. We have 3,000 to 5,000 neurologists in this ECTRIMS meeting, and the room is full because of these, because there are more than 2 million people worldwide suffering from multiple sclerosis, and at least 350,000 MS patients in Europe. And we are here because you know that multiple sclerosis affects mainly young adults, which all the implications that you know very well, much better than I do. The first problems, and I think has been mentioned here, is that sometimes first symptoms are a little bit not very clear, a little bit varied and unpredictable. People could complain about weakness in one of or both legs. Some patients said, well, I have some numbness and tingling in my face, dizziness, some problems in the vision, but nothing very clear. That means that many of you probably has visited quite a number of doctors in the early phases of the disease, traumatologists, rheumatologists, even psychiatrists. And this is a difficult period. And this is because multiple sclerosis is considered to be the chameleon of neurology, because multiple sclerosis has quite a number of very different symptoms and signs. And I like this sentence very much by Matthews, is the diversity of symptoms, signs, and course of multiple sclerosis that continues to astonish even the most experienced physician, affords almost unlimited opportunity for misdiagnosis. And I think this is still true. So another concept is that diagnosis in the past, probably when Alan was a little bit younger, was delayed for years in many cases, because we didn't have any MRI. We just have CT scans, which were not very helpful at all, and we had to wait for a number of years before diagnosing multiple sclerosis. But now, of course, we are much better. For the diagnosis of multiple sclerosis, we have to demonstrate dissemination in time and space. We have to find no other better explanation, which is the tricky thing in the diagnostic criteria. And also, we can make the diagnosis quite earlier with the MRI and CSF study. Therefore, after a CIS, after a first symptom suggestive of multiple sclerosis, you can get nowadays the definite diagnosis of multiple sclerosis after a couple of months. So that's the time point, the time of diagnosis. This is a bad time also for the doctor, because you have to give patients bad news. And these bad news are due to the unpredictable, variable nature of MS and the possibility of increasing disability. That means that a diagnosis can have substantial psychological consequences, and this is very clear for all of you. These are the reactions to MS in general, mainly the first step of the MS diagnosis: anger and frustration, fear, anxiety and worry. The Neil, I think Sonja, the first time was a little bit like that. You didn't want to hear about that. Feelings of unreality, confusion, depression, guilt, shame, hope, quite a number of them, even in combination. So, what does it mean? This means that we doctors have to spend as much time as necessary to explain the whole situation, to explain the diagnosis very clearly and with a friendly explanation. That probably several visits will be necessary at the beginning, and perhaps we should implicate other relatives when necessary. That depends very much on the personality of the patient, of the person, and also of the age of the person. But you also have to demand this. You also have to ask the doctor, well, spend time with me, explain me perfectly well that I could understand what is happening now. And I think this, in many countries, in many hospitals, doesn't happen. This is very important, what I have just told you. Let me show you this very recent paper published in a very nice journal, Multiple Sclerosis 2007, about patient information and coping styles in multiple sclerosis. These authors had a hypothesis. The hypothesis was the quality of information and how it is presented at the time of diagnosis will influence a patient's coping. And what they did is to ask patients 4 questions concentrating on the content of the information. Was the information about the disease MS satisfactory? Did they inform you about the treatment for the disease? Did you get information about how to handle your job, family, and friends? Did you get information about what it implies to live with MS? But also, 5 statements about the experience of the information were asked. First, they gave me adequate information about MS. The second one was I had time enough to think through what they told me and to ask questions. 3 was they told me the consequences of MS in my daily life, or the possible consequences for my daily life. They encouraged me to ask questions. I felt cared for. That was the questionnaire, more or less. These are the results. 43 of patients were dissatisfied or very dissatisfied with the information by the time of diagnosis. And on the other hand, patients who were satisfied with the information employed avoided coping to a lesser extent, which is very good. We don't have to use this sort of coping. And more actively, both plan and seek about the situation. So it seems that diagnosis, the way you give the diagnosis, the time you spend with the diagnosis, the quality of the time given the diagnosis and the prognosis is really important for the long term. So in conclusion from this study, optimizing the information process in the early phase of the disease may induce coping styles that produce a better adaptation to living with MS. I think that's one clear question, one clear concept. We have another problem nowadays. As I mentioned before, we are able to perform a very early diagnosis, and in fact, we have very early treatment available in many patients. Mostly those patients with an abnormal MRI on a first episode suggestive of demyelinating disease. That's what we have in many countries in Europe, at least. So the question here is, this early treatment has any impact on the quality of life of patients?